Good morning. I'm Dr. Saisha, as consultant surgical gastroenterologist and assistant professor, Department of General Surgery, Oxford Medical College. Today we'll be speaking about Barrett's esophagus. What is Barrett's esophagus? Barrett's esophagus is a complication of chronic gastroesophageal reflux disorder. It is characterized by the intestinal metaplasia within the lower end of the esophageal squamous mucosa. It is a pre-malignant condition and it is associated with increased risk of adenocarcinoma of the lower end of the esophagus. This picture shows a mechanism of the gastroesophageal reflux disorder. The first picture shows an intact lower esophageal sphincter. When there is laxity of the lower esophageal sphincter, there is reflux of gastric acid into the lower esophagus. Thus, there is metaplasia mucosa of the lower esophagus. That is, there is metaplastic transformation. The stratified squamous epithelium of the lower esophagus changes into metaplastic intestinal mucosa with goblet cells. And the squamocolumnar junction moves up into the esophagus. And this intestinal metaplasia predisposes the patient for adenocarcinoma of the lower end of the esophagus. The incidence and risk factors: males in the age group of 50 to 60 years are usually affected, and it usually affects Caucasians. Approximately 10% of patients with chronic GERD develop Barrett's esophagus, and hiatus hernia, overweight, central obesity, current or past history of smoking. The clinical features include generally that of GERD, frequent heartburn, difficulty in swallowing food, odynophagia, and less commonly chest burn or retrosternal pain. Etiology: there is chronic inflammation, smoking, central obesity, hiatus hernia, and scleroderma. In scleroderma, the salivation decreases. It is an autoimmune disorder due to which the turnover of acid into the stomach is decreased because of decreased salivation, and the protective barrier is lost, because of which there is metaplastic transformation of the lower end of the mucosa of the lower end of the esophagus into columnar intestinal mucosa with goblet cells. Pathophysiology: there is acid reflux, which results in epithelial injury. And epithelial injury, there is inflammation and epithelial repair. And this is usually stratified squamous epithelium. Due to metaplastic changes, there is columnar epithelium that develops over there. That is specifically intestinal metaplasia, including goblet cells. In 10% of the patients with chronic GERD, there is chronic reflux of gastric juices, which results in chronic reflux esophagitis and mucosal damage, which results in epithelial layer repair through columnar metaplasia. The progenitor stem cells in the esophagus that were normally differentiated into squamous cell epithelial cells are reprogrammed to develop into columnar epithelial cells. These metaplastic columnar cells are more resistant to reflux injury, and there is reflux columnar metaplasia which predisposes the patient to adenocarcinoma. The diagnosis is usually by upper GI endoscopy, and multiple biopsies are taken in the four quadrants of the gastroesophageal junction, and microscopic examination is performed, which shows columnar metaplasia with goblet cells. The types of Barrett's esophagus is based upon the length of the esophagus that is involved. It might be either less than or more than 3 centimeters. It is short segment Barrett's esophagus when less than 3 centimeters is involved, and it is called as long segment Barrett's esophagus when more than 3 centimeters of the lower esophagus is involved. The normal esophagus, here this is a pictorial representation of the normal esophagus and patient with Barrett's esophagus. The picture A shows a normal squamous esophagus with a squamocolumnar junction at the level of the gastroesophageal junction and the stomach. Picture B shows a normal esophagus with a hiatus hernia, wherein the squamocolumnar junction is moved up and the hiatus hernia is in the thoracic portion. C shows Barrett's esophagus. You might see an ulceration over there. It looks like a short segment Barrett's esophagus, which is less than 3 centimeters in length. And this is due to a predisposing factor of hiatus hernia. And long segment Barrett's esophagus is shown in picture D, wherein the squamocolumnar junction moves further up. That is, the squamocolumnar junction is more than 3 centimeters, and thus it becomes a long segment Barrett's esophagus. The location, it is usually located in the lower part of the esophagus, that is at the level of the gastroesophageal junction. It looks like a red velvety mucosa which extends upwards from the gastroesophageal junction. Metaplastic mucosa alternates with residual smooth pale squamous mucosa proximally. It interfaces with light brown gastric mucosa distally. This picture shows that of a Barrett's esophagus. You can make out a junction between the Barrett's esophagus, that is the columnar epithelium, and the normal squamous, stratified squamous epithelium of the esophagus. This looks like a long segment Barrett's esophagus. You might see at the end of the tunnel that there is a gastroesophageal junction. Again, this shows a picture of a patient with Barrett's esophagus. Multiple biopsies have to be taken in 4 quadrants and have to be subject for a histopathological examination. The histopathological examination will reveal intestinal columnar mucosa with goblet cells. Intestinal or columnar metaplasia with goblet cells. Goblet cells have distinct mucous vacuoles. Mentioning the presence or absence of dysplasia and the grade of dysplasia present, whether low grade or high grade dysplasia, is important. Mentioning the presence or absence of neoplastic cells and their locations, whether they are present in the lamina propria or beyond that, that is in case of invasive carcinoma. Here you might see that in picture A, you have stratified squamous epithelium, which has been taken from the normal esophagus. And picture B shows an endoscopic representation of a patient with Barrett's esophagus. And you might see this arrow mark from down represents the normal gastroesophageal junction. And a biopsy taken from the region of Barrett's esophagus shows columnar epithelia, that is intestinal metaplasia with multiple goblet cells. Goblet cells are mucus producing cells. This picture shows multiple areas of intestinal metaplasia with multiple goblet cells, and the vacuoles represent mucus producing goblet cells.